Good evening. I'm with Bearing Witness. Tonight, we're reviewing records on fraud in Minnesota that have received little attention. We'll walk through what the documents show, why they matter, and who they affect. Hello, and welcome back to Bearing Witness. If you're new to this channel, we're glad you found us. And if you're a returning subscriber, we truly thank you for supporting our work. This work is focused on Minnesota public records, civic whistleblower reports, and internal processes that most news organizations do not track closely or contextualize. Because of that, we are able to identify patterns of fraud and procedural abuse that often go unreported, despite their impact on real people. This work is for the victims, for accountability, and for the betterment of Minnesota. In our last episode, we went over Jensen et al. V. Minnesota Department of Human Services, a 2011 $3 million class action settlement that was won by the victims of the DHS Meadow facility, as described in the Just Plain Wrong investigative report. The U.S. District Court of Minnesota monitored that settlement until 2020. As part of the settlement agreement, the Enterprise State of Minnesota incorporated May 11, 1858, and its Department of Human Services were both court-ordered to create what's known as the Olmstead Plan. The Olmstead Plan is a statewide framework aimed at removing disabled persons from state-operated facilities and enabling them to receive delivery of their health care among the general population with fellow Minnesotans. Tonight, on Bearing Witness, we go over the details of that plan. Minnesota's Olmstead Plan, a court-ordered reckoning rooted in Jensen v. Department of Human Services. Minnesota's Olmstead Plan did not emerge from legislative vision or voluntary reform. It exists as the direct consequence of litigation, federal oversight, and judicial findings that the state of Minnesota was failing people with disabilities by unnecessarily segregating them from community life. The plan traces its legal foundation to Olmstead v. LC, a landmark 1999 United States Supreme Court decision interpreting the Americans with Disabilities Act, ADA. In that case, two women, Lois Curtis and Elaine Wilson, who had mental illness and developmental disabilities, and were voluntarily admitted to the psychiatric unit in the state-run Georgia Department of Human Services Regional Hospital. After completing their medical treatment, mental health professionals determined that each woman was ready to transition to a community-based program. Despite those clinical recommendations, both women remained institutionalized for several years after their treatment had concluded like prisoners. They subsequently filed suit under the Americans with Disabilities Act, ADA, seeking release from the hospital, arguing that they were being unjustifiably institutionalized despite being capable of living in the community with appropriate supports. The court agreed, ruling that under the ADA, individuals with disabilities have the right to receive services in the most integrated community-based settings appropriate to their needs. On June 22, 1999, the United States Supreme Court ruled in Olmstead v. LC that the unjustified segregation of individuals with disabilities constitutes discrimination under Title II of the Americans with Disabilities Act. The court held that public entities are required to provide services in community-based settings when three conditions are met. The services are appropriate, the individual does not oppose community-based care, and the accommodation can be made reasonably, considering the public entity's available resources and its obligations to others receiving disability services. In its decision, the court emphasized two fundamental principles. First, placing individuals in institutions when they are capable of living in community settings reinforces unfounded assumptions that they are unable or unworthy to participate in community life. Second, institutional confinement significantly restricts daily life, limiting family relationships, social interaction, employment opportunities, economic independence, educational advancement, and cultural participation. As a result of that ruling, states were required to develop formal Olmstead plans outlining how they would comply with federal law by reducing unnecessary institutionalization and expanding community-based services. For Minnesota, compliance did not come voluntarily. Jensen v. Minnesota Department of Human Services. In 2012, Minnesota entered into a settlement agreement in Jensen versus Minnesota Department of Human Services, a federal lawsuit alleging that the state was violating the ADA and the Olmstead decision by unnecessarily segregating people with disabilities and failing to provide adequate community based alternatives. As part of that settlement, Minnesota agreed, under court supervision, to establish a comprehensive Olmstead Plan. The plan was ultimately approved by the federal court in September 2015, formally placing Minnesota under ongoing judicial oversight to ensure compliance. The vision articulated in the Minnesota Olmstead Plan is explicit. People with disabilities should be living, learning, working, and enjoying life in the most inclusive settings possible. Importantly, the plan is not limited to programs administered by the Minnesota Department of Human Services. It applies across all Minnesota state agencies and governs the full spectrum of public services affecting people with disabilities. In effect, the Olmstead Plan functions as a statewide compliance framework, a binding roadmap designed to correct systemic failures identified through litigation. 13 topic areas, measurable obligations. Minnesota's Olmstead Plan is structured around 13 topic areas, each with measurable goals that are reviewed and updated annually. The Olmstead Implementation Office solicits public input each year on proposed changes, reinforcing that the plan is intended to be a living document rather than a symbolic gesture. Those topic areas include person-centered planning, ensuring that services and supports are designed around the needs, preferences, and goals of the individual, rather than institutional convenience or administrative efficiency. Transition services supporting individuals in moving from more restrictive or segregated settings into more inclusive homes and community environments. Housing and services providing informed choice and appropriate funding so individuals can decide where they live, with whom they live, and in what type of housing arrangement. Employment, increasing access to competitive, meaningful, and sustained employment in integrated settings, with supports for individuals who want to work in the general labor market. Lifelong learning and education, expanding inclusion in K-12 classrooms and increasing enrollment of students with disabilities in inclusive, post-secondary education programs. Waiting lists, working toward the elimination of waiting lists for medical assistance disability waivers, a long-standing barrier to timely services. Transportation, improving pedestrian accessibility and expanding access to public transit throughout the state. Healthcare and healthy living, reducing healthcare disparities by increasing access to preventive care, mental health services, dental care, and other essential health services. Positive supports, reducing the use of restrictive procedures, including restraints, in schools and adult service settings such as residential and vocational programs. Crisis services, shifting away from crisis responses that remove individuals from their homes and communities and expanding brief, effective supports that allow people to remain or quickly return to their homes. Preventing abuse and neglect, reducing the incidence of abuse and neglect experienced by people with disabilities through systemic safeguards and oversight. Community engagement, increasing participation by people with disabilities in self-advocacy, governor-appointed boards and commissions, and public planning initiatives. Assistive technology, the 13th topic area. Assistive technology does not have standalone measurable goals. Instead, assistive technology is integrated throughout the plan, with an overarching objective of expanding access to technology that enables individuals to live and work in the most inclusive settings possible. A plan born of enforcement, not intent. The Minnesota Olmstead Plan is often discussed as a policy achievement. The record shows otherwise. It is the product of enforcement, of judicial intervention prompted by systemic failures that left people with disabilities segregated, underserved, and excluded from community life. That distinction matters. The plan's existence reflects not only a legal obligation under federal law, but also a continuing responsibility. Compliance is not assumed. It must be demonstrated, measured, and scrutinized year after year. As Minnesota continues to expand publicly funded Medicaid programs and community-based services, including housing-related initiatives, the Olmstead Plan remains a central legal and ethical benchmark. It defines what inclusion is supposed to look like, and by implication, what failure looks like when those standards are not met. This work is not abstract. It affects real people, real homes, real livelihoods, and real safety. Bearing Witness continues to examine the public records, litigation history, and implementation realities surrounding Minnesota's Olmstead obligations, not as an academic exercise, but in service of victims, accountability, and the betterment of Minnesota. Once again, we thank you for being here with us. Until the next episode, signing off.